Hello, everyone. Welcome to our lecture on intestinal obstruction and paralytic ileus, which is part of our concept of elimination. So throughout this lecture, we're going to talk about what happens when normal flow of intestinal contents is disrupted, whether mechanically or functionally, and the significant implications for patient outcomes. So by the end of this lecture, you'll understand the pathophysiology, key assessment findings, and essential nursing interventions to manage these conditions effectively. So let's get started. All right, so now let's talk about the pathophysiology of intestinal obstructions, otherwise known as a bowel obstruction. So these conditions can be classified as either partial or complete blockages, and then they're further categorized as either a mechanical or a non-mechanical obstruction. A mechanical obstruction occurs when the bowel is physically blocked, which can happen due to adhesions from previous surgeries, fecal impactions, tumors, strictures caused by things like Crohn's disease, intussusception, or volvulus. And in these cases, surgical intervention may be necessary to resolve the obstruction. On the other hand, a non-mechanical obstruction, also known as a paralytic ileus, results from a neuromuscular disturbance where peristalsis slows or it stops altogether. So this leads to a functional blockage without any physical impediment. So a paralytic ileus is often seen post-operatively due to the handling of intestines during surgery. Intestinal function may be lost for a few hours, even up to several days in these cases. So the primary focus of treatment for both types of obstructions includes restoring fluid and electrolyte balance, decompressing the bowel, and addressing the underlying cause. So understanding the differences between these two types of obstructions is very important to determine the most appropriate intervention. All right, so now let's take a closer look at what happens in the body during an intestinal obstruction. So whenever an obstruction occurs, intestinal contents will begin to accumulate above the area that's affected. And this leads to abdominal distension as the intestines aren't able to absorb the contents or move waste through the GI tract. So to compensate, especially in the case of a mechanical obstruction, the body is going to increase peristalsis in an attempt to push the contents forward. However, this often backfires. It leads to increased secretion of fluids into the intestine, which can further worsen the distension. And over time, the bowel starts to become edematous, and the capillaries in the intestinal walls become more permeable. So this allows plasma to leak into the peritoneal cavity, with additional fluid becoming trapped in the intestinal lumen. So as a result, the absorption of fluids and electrolytes into the vascular system becomes significantly reduced. So this chain culminates in hypovolemia and electrolyte imbalances, which are very common and serious complications of an intestinal obstruction. So understanding this whole process can help us better appreciate the urgency of effective management and intervention for these patients. So now let's talk about some of the potential complications that are associated with bowel obstructions, as these can significantly impact a patient's prognosis. So first we have acid-base imbalances. The location of the obstruction determines the type of imbalance. So if the obstruction is high in the small intestine, gastric hydrochloric acid is going to be lost, leading to metabolic alkalosis. This is often caused by persistent vomiting. Conversely, if the obstruction occurs at the end of the small intestine or in the lower intestinal tract, then alkaline fluids are lost, which results in a metabolic acidosis. So this just really shows the importance of understanding where the blockage is located whenever we're assessing and treating these patients. Next, there are fluid and electrolyte imbalances, which can become life-threatening. Severe hypovolemia, which is due to persistent vomiting, can result in an acute kidney injury or even death if it's not treated quickly. Monitoring fluid status and electrolyte levels is very, very important in managing these patients. So lastly, let's talk about peritonitis, which may occur with or without a bowel perforation. So the risk of peritonitis increases significantly in the cases of a strangulated obstruction, where blood flow to the intestine gets compromised. And in these cases, bacteria can release endotoxins into the peritoneal or the systemic circulation, which can potentially lead to septic shock. Also, a strangulated obstruction can cause a significant blood loss into the peritoneum, which increases intra-abdominal pressure and potentially leads to acute compartment syndrome. So these complications really just show why prompt recognition and intervention are so important whenever we're managing bowel obstructions. So now let's go over some of the different risk factors that are associated with mechanical bowel obstructions. So the most common causes of a mechanical obstruction include adhesions or scar tissues that are usually the result from previous surgeries or other pathologies. Another common cause is a benign or malignant tumor that can obstruct the bowel, especially in older adults. Other causes include complications from appendicitis, hernias, and fecal impactions, which are especially common in the older populations, due to their slower bowel motility and decreased hydration. In some patients, chronic conditions like Crohn's disease or even prior radiation therapy from like cancer can lead to strictures, which are just narrowed segments of the bowel. Two particularly severe forms of a mechanical obstruction are intussusception, where a segment of the intestine actually telescopes into itself. And then we also have a volvulus, which is a twisting of the intestine that can cut off blood flow. So these are medical emergencies, an intussusception and volvulus. They require immediate medical intervention. Also, fibrosis, which can be caused by conditions like endometriosis or even diverticulitis in older adults, can also block the intestinal lumen. So while all of these risk factors may vary by age and individual health status, recognizing them is very important for prevention, for diagnosis, and for treatment. All right, so now let's look at the risk factors for non-mechanical obstructions, especially a paralytic ileus. This condition, also referred to as a postoperative ileus, is a temporary loss of intestinal function that's caused by factors that disrupt peristalsis. So one of the most common causes is the handling of intestines during an abdominal surgery, which can temporarily paralyze the bowel. Neurogenic disorders and spinal fractures can also impair nerve signals that are needed for proper intestinal motility. Electrolyte imbalances, especially hypokalemia, which is low potassium, can also predispose patients to a paralytic ileus, making it so important to monitor and correct any electrolyte levels in high-risk individuals. Also, paralytic ileus may also occur as a consequence of peritonitis, where, again, peritonitis is the leakage. It occurs because of leakage of bowel contents into the abdominal cavity, and it leads to inflammation and infection in the peritoneum. So another serious case is intestinal ischemia, which occurs when blood flow to the intestines is reduced or it's blocked due to arterial or venous thrombosis or an embolus in the mesenteric blood vessels. If this is left untreated, it can result in a bowel infarction, gangrene, and ultimately sepsis or septic shock. So understanding all of these risk factors is very important for prevention and early intervention, especially in those postoperative patients or those who have predisposing conditions. All right, so now let's get into our nursing assessment. And an accurate and thorough assessment is very important whenever a bowel obstruction is suspected. So as usual, we're going to start by gathering the patient's history. So first, we're going to ask about any past GI disorders, any previous surgeries, and treatments. These can provide clues about any potential adhesions, strictures, or any other underlying cause. We also want to ask about any recent nausea or vomiting. And it's important to note the color of the patient's emesis, because this can give us pretty vital information. A greenish yellow vomitus might suggest bile, while hematoemesis indicates bleeding. Next, we want to perform a detailed pain assessment. So pay close attention to the onset, aggravating and alleviating factors, and any patterns in the pain. Keep in mind that severe pain followed by sudden relief might signal perforation, which requires immediate intervention. We also need to assess elimination patterns, including any passage of gas, the last bowel movement, including the last time that they had or last day they had a bowel movement, and then the character and the consistency of that bowel movement. We may also need to ask if they have had any hiccups. This is a very common finding in all types of intestinal obstructions, and it doesn't need to be overlooked. Also, we want to explore the patient's family history, especially for any history of colorectal cancer. And finally, we need to keep an eye on the patient's vital signs. Uncomplicated obstructions rarely cause a fever greater than 100 degrees. So a higher temperature along with tachycardia and hypotension or abdominal rigidity can indicate complications like strangulation, peritonitis, or even ischemia. And all of these signs warrant immediate reporting to the primary healthcare provider. So this thorough history-taking process is very important to recognize those early cues that can guide diagnosis and treatment. All right, so moving on to our physical exam, and this is where careful observation, auscultation, and palpation are very important. So we're going to start by talking about mechanical obstructions in the small bowel or the small intestine. So these patients often report mid-abdominal pain or cramping, which may initially be sporadic, allowing moments of comfort between episodes of pain. If strangulation occurs, then the pain becomes a lot more localized and it's constant, which requires immediate attention. With our small bowel obstructions, vomiting is a significant symptom, especially with obstructions that are proximal in the small intestine. Early on, it may be profuse vomiting and it may be projectile, and it may contain bile and mucus. But as the condition progresses, then the vomitus may turn kind of an orangish brown color and may have a very foul smell. And this is just due to bacterial overgrowth in the bowel. They're not actually vomiting up fecal material. You may also see upper abdominal distension in these cases. You may see visible peristaltic waves, especially in your thinner patients. So these can sometimes be seen because the intestine is attempting to push contents past the obstruction. Obstipation, which is the complete absence of stool or gas, typically occurs with a complete obstruction. However, you may still see some diarrhea with a partial obstruction. That's just because that liquid stool content is leaking its way around that partial obstruction. So these symptoms can lead to very severe fluid and electrolyte imbalances. For a mechanical obstruction in the large bowel or the colon, then the symptoms tend to be less dramatic, but they're still concerning. Here, the patients may describe mild, kind of colicky abdominal pain that's intermittent, and it's going to be localized to the lower abdomen. Lower abdominal distension is a very common finding in these patients, and our patients may also experience obstipation, or in cases of a partial obstruction, they may be passing like ribbon-like stools. Vomiting is going to be less frequent in our large bowel obstructions, but it can still occur, typically without the profuse nature that we see in small bowel obstructions. And also fluid and electrolyte imbalances are generally minor in these cases, but it's still worthy to note that they can get worse over time if the obstruction's not resolved. When we do our abdominal assessment for both small bowel and large bowel obstructions, we may hear high-pitched bowel sounds or borborygmy, as it's otherwise known, proximal to the obstruction. And this just shows the bowel's increased activity as it's trying to push contents forward. However, distal to the obstruction, you may hear hypoactive or absent bowel sounds, which indicates the progression of the obstruction. So initially they may be hypoactive, and then later on in the disease process or the stage of the obstruction, then you might hear absent bowel sounds. All right, so moving on to assessing a patient with a suspected non-mechanical obstruction, again known as a paralytic ileus. And here it's important to recognize key physical findings that differentiate it from a mechanical obstruction. So pain is often going to be described as constant, and it may be diffuse rather than colicky or cramping, which is what we see in mechanical obstructions. If vascular insufficiency or infarction is the underlying cause, then pain may be severe and it may be unrelenting, which indicates a very critical condition that requires immediate intervention. Abdominal distension is typically present as the intestines are failing to propel contents forward due to that lack of peristalsis. And this can be observed during inspection, and it may worsen as the condition progresses. On auscultation, bowel sounds are going to be decreased in the early stages of obstruction and then may become completely absent as the condition advances. These findings reflect a lack of intestinal motility, which again is a hallmark of our paralytic ileus. Vomiting is another common symptom, typically involving gastric contents and bile. So unlike in mechanical obstructions, the vomitus rarely has a foul odor, and it's usually not profuse. This distinction can help in differentiating between the two types of obstruction. And finally, obstipation, which again is the inability to pass stool or gas. This may or may not be present in a non-mechanical obstruction. This symptom is often associated with a mechanical obstruction, and it's therefore less reliable in a paralytic ileus. So by recognizing these findings during your physical exam, it can help guide any further diagnostics as well as any further interventions. By identifying the characteristics of a non-mechanical obstruction, we can address underlying causes like electrolyte imbalances, peritonitis, or vascular issues, and we can ensure timely and effective treatment. When a bowel obstruction is suspected, lab tests and imaging play pretty big roles in the diagnostic process. So starting with our lab test, it's important to note that there's no definitive lab test to confirm the diagnosis of either a mechanical or a non-mechanical obstruction. However, lab results can help provide clues to the patient's condition. For example, signs of dehydration may be common, along with elevated hemoglobin and hematocrit levels, and that's usually just due to the dehydration. Also, increased BUN and creatinine levels can be seen, and those are just your kidney labs, which can be elevated in dehydration as well. Your serum electrolytes may also be affected. We may see elevated sodium, chloride, and potassium levels, especially in cases of dehydration. In cases where strangulation is present, you may see an elevated white blood cell count, which indicates infection or inflammation. And also, our serum amylase levels can rise if the obstruction causes damage to the pancreas. Now let's move to diagnostic imaging, which is key in determining the presence, the cause, and location of an obstruction. Abdominal x-rays are often going to be the first imaging study that's done. They help evaluate gas patterns and detect the presence of free air, which could suggest a perforation. For more detailed visualization, CT scans or MRIs are going to be preferred. These imaging modalities just provide comprehensive information about the location and the cause of the obstruction, whether it's a mechanical blockage, a volvulus, or an intussusception. Finally, endoscopic procedures like a sigmoidoscopy or a colonoscopy may be done to investigate the cause of the obstruction, especially in cases of suspected colorectal cancer or strictures. However, endoscopy is typically avoided if perforation or complete obstruction is suspected, just simply due to the risk of exacerbating the condition. All right, moving on to our nursing interventions. So here our primary goal is to identify and relieve the obstruction while minimizing complications and discomfort for the patient. So first we're going to look at our non-surgical treatment options. For partial obstructions where there's no evidence of strangulation or ischemia, non-surgical management is going to be the treatment of choice. And this approach is particularly effective for our paralytic ileus and non-mechanical obstructions. So the first step is to keep the patient NPO. This just reduces stimulation of the GI tract and it allows the bowel to rest. Next, most patients will require the insertion of an NG tube, specifically a Salem sump tube. This tube is placed into the nose and into the stomach, where it's attached to low continuous suction. So the NG tube serves to decompress the bowel, effectively draining excess fluid and air, which reduces abdominal distension and discomfort. So the unique feature of the Salem sump tube is that it has a vent or a pigtail, and this prevents damage to the stomach lining during suction. So this vent allows air to enter the stomach, avoiding negative pressure that can lead to mucosal injury. A Levin tube, which does not have this little vent that the Salem sump has, should only be used with low intermittent suction, not continuous. A Levin tube is less commonly used in practice today, but you may still see them. For the most part, Salem sumps are what most facilities use. It's very important to monitor the NG tube for proper functioning and for placement. If the tube becomes dislodged or obstructed, then you may notice decreased gastric output, stasis of the tube's contents, or the patient may complain of worsening nausea, and they may have worsening abdominal distension. In these cases, the tube may need to be repositioned or replaced, and then we need to confirm placement with an X-ray. Also, to maintain the NG tube's functionality, we need to irrigate the tube with 30 mL of normal saline every 4 hours, or as directed by the provider. This just helps to clear any obstructions and ensures effective drainage. In some cases, other non-surgical interventions may be used. For example, lower fecal impactions can often be resolved with manual disimpaction and enema administration, while intussusception can actually sometimes respond to hydrostatic pressure changes during a barium enema. So by employing these non-surgical approaches, we can restore normal bowel function, we can alleviate symptoms, and we can prevent the need for a more invasive procedure. All right, so going over a few more non-surgical management interventions. So for like our lower fecal impactions, I think I mentioned on the last slide, the obstruction is usually resolved through manual disimpaction and enema administration. This just helps to remove the blockage and restore normal bowel function. In the case of a post-op ileus or POI, a specific medication called alvamopin can be administered. This is an oral peripherally acting mu-opioid receptor antagonist that works by increasing GI motility. It's typically prescribed for short term, and it can significantly reduce the duration of an ileus. So now let's look at some interventions that apply to all intestinal obstructions. First being IV fluid and electrolyte replacement. This is very important because most patients with obstructions are in PO, and they may experience significant fluid and electrolyte imbalances due to vomiting or nasogastric suction. Replacement fluids like acetonic solutions like normal saline or lactated ringers are often administered, sometimes with added potassium, just based on the patient's lab values. It's important to monitor for any signs of fluid overload, especially in our older adults or those who have conditions like heart failure or chronic kidney disease. We also need to monitor vital signs and measures of fluid status. This includes tracking urine output, skin turgor, and mucous membranes for hydration every 2 to 4 hours, just really kind of depending on symptom severity. Getting a daily weight is going to be the most reliable indicator of fluid balance. For patients with prolonged obstructions or nutritional deficiencies, and parenteral nutrition may be prescribed. With this, we need to collaborate with the dietitian and the healthcare provider to make sure the patient's nutritional needs are met. And we also have to do our pain assessment and management. These are very important. So pain from a mechanical obstruction, again, is usually colicky and intermittent, while a non-mechanical obstruction causes more constant discomfort. So we want to monitor for changes in the character, location, and severity of pain. Sudden worsening can indicate complications like perforation or peritonitis. We also want to use caution with analgesics because these can sometimes mask symptoms or they may slow intestinal motility. In these cases, non-pharmacologic pain management techniques like positioning or relaxation strategies can be helpful. And finally, positioning the patient in a semi-Fowler's position can also help relieve pressure from the abdominal distension. It can also improve thoracic expansion, and it can promote easier breathing. So for patients with complete mechanical obstructions or strangulated obstructions, surgical intervention becomes very important. So the most common procedure is an exploratory laparotomy, which can be performed through either a traditional open approach or a minimally invasive laparoscopic surgery. So with the open approach, the surgeon makes an incision to access the abdominal cavity. Here, adhesions can be lysed, tumors can be removed, or infarcted bowel can be resected. Severe cases may require more extensive procedures, such as a colectomy or even a colostomy. With the laparoscopic approach, so this is a minimally invasive technique that uses small incisions and a camera to assess the obstruction. It results in less blood loss, faster recovery, and fewer post-op complications. Patients undergoing laparoscopic surgery often have a shorter hospital stay with 1 to 2 days as compared to 3 or more days with that open approach. In both cases, The surgeon's choice of technique just depends on the location, the cause, and the severity of the obstruction, as well as the patient's overall condition. So now let's talk about our nursing actions and surgical management. So as nurses, we play a pretty big role in ensuring the success of surgical intervention. So we're going to go over some of the key responsibilities before, during, and after the procedure. So our pre-op care, patient and family education. So we need to ensure that the patient and family understand the procedure and its purpose. Many patients with complete obstructions may feel too ill or too sick to comprehend any detail. So reinforce teaching with family members or caregivers. We're also going to help prepare for surgery. So we're going to verify that the patient is NPO and prepped for the surgical environment. We will monitor hemodynamic stability, especially during, before, during, and after really surgery. So patients who have a strangulated obstruction can experience significant blood loss or fluid imbalances. So we want to monitor for vital signs. We want to assess for hypotension and track signs of shock or for sepsis. We need to administer IV fluid replacement as prescribed, again, including isotonic solutions like normal saline or lactated ringers. And again, sometimes we add some potassium just based on the patient's electrolyte levels. As far as our post-operative care, so let's talk about NG tube management. So in the open approach, an NG tube is often placed to decompress the bowel, and it's going to remain in place until peristalsis resumes. We're going to monitor for proper functioning of the NG tube, making sure that it stays patent and that the output is being recorded. If the tube becomes clogged, repositioning or replacing it may be necessary. We also want to monitor bowel sounds. So regular auscultation is very, very important to determine when peristalsis returns, which helps guide our progression from NG tube suction to actual dietary intake for our patients. So speaking of that, let's talk about our dietary advancement. So once the bowel function resumes, then we can start the patient on a clear liquid diet. The NG tube is going to be disconnected and capped temporarily after the patient consumes liquids to evaluate their tolerance. If no nausea or vomiting occurs, then typically the NG tube can be removed and the diet can be gradually advanced. Also, part of our post-op care is going to be pain management. So we need to assess pain regularly, noting any changes in the character, location, or severity. We need to report changes immediately because this can sometimes indicate complications like perforation or even peritonitis. Pain control often requires a balance between pharmacologic and non-pharmacologic strategies. So for example, morphine and other opioids can slow that intestinal motility, so we want to be sure that we use them cautiously. And we may need to consider alternatives, again, like repositioning or relaxation. Also, we need to prevent complications. So we're going to be watching for any complications that may be specific to the surgical intervention. So things like infection, wound dehiscence, or a prolonged ileus. For patients with strangulation or gangrene, we're going to monitor for signs of sepsis or hemodynamic instability. When we talk about recovery and outcome, so patients who are undergoing a laparoscopic surgery typically, again, experience that faster recovery. They typically have less post-op pain and they have fewer complications than those who have an open approach. Their recovery times are going to be significantly shorter, again, with some cases only requiring a 1 to 2 day hospital stay. For patients who require that open surgery, then the recovery process is going to be longer, but with proper care and monitoring, they can still achieve very excellent outcomes. So your post-op goals focus on resuming that normal bowel function, as well as ensuring adequate nutrition and preventing any life-threatening complications. All right, so now that we've discussed the interventions for bowel obstructions, let's focus on the transition from hospital care to home care and self-management education. So first, we're going to talk about home care management. So the plan for discharge in home care really depends on the cause of the obstruction and the treatments the patient received. For patients who resolve their obstruction without surgery, education focuses on strategies to prevent recurrence. For example, older adults recovering from a fecal impaction are going to need guidance on maintaining a bowel regimen. For post-surgical patients, It's important to assess their ability to manage at home, especially if they require incision care or colostomy management. Next, self-management education is very important. Patients need to recognize symptoms of potential complications. So we want to teach them to report abdominal pain, distension, nausea, vomiting, or changes in bowel patterns quickly because these can indicate a recurrent obstruction. However, we need to reassure them that a recurrent paralytic ileus is pretty uncommon. For older adults, specific interventions can help prevent fecal impactions, including incorporating a high-fiber diet, which includes foods like raw vegetables, raw fruits, and whole grains into their diet. Adequate fluid intake, especially water, is also going to be essential, as well as regular exercise, such as daily walking, so that we can promote that intestinal motility. For post-surgical patients, focusing on providing clear instructions for incision care, drug therapy, and activity limitations are important, as well as the importance of follow-up appointments. Patients may be prescribed an oral opioid analgesic like oxycodone for incisional pain. And if opioids are used, they may need to be paired with a stool softener or a laxative, such as like Docusate with Senna, just to prevent constipation and to reduce the risk of an obstruction recurrence. Lastly, the need for follow-up care will vary depending on the cause and the treatment of the obstruction. So we may need to collaborate with case managers to arrange resources such as home care nurses for patients who may require help with incision or colostomy care. Ensure patients understand the importance of their follow-up visits and to monitor their progress and address any concerns. So proper care coordination and patient education helps to empower individuals to take that active role in their recovery and to reduce the risk of any future complications. We always want to encourage that open communication between patients, caregivers, and healthcare providers during this transition process. All right, so with this slide, it's just kind of an overview of a bowel obstruction or an intestinal obstruction. So again, this is when the normal flow of contents through the small or large intestine is interrupted. And as a result, problems with nutrient and fluid absorption as well as waste elimination can come up, which causes a whole other cascade of symptoms and complications. So talking about the clinical manifestations. So patients with a bowel obstruction commonly present with cramping, abdominal pain, vomiting, constipation, and abdominal distension. And again, these symptoms just vary based on the type and the location of the obstruction, but they're critical to recognize early for timely intervention. As far as treatment goes, our strategies typically focus on relieving symptoms. In a lot of cases, obstructions can resolve on their own with conservative management. However, if symptoms persist or if complications like strangulation or ischemia develop, then surgery may be necessary to correct the underlying issue. The primary goals of nursing care for these patients are to maintain fluid and electrolyte balance and to monitor for complications like dehydration or worsening obstruction. By addressing these priorities, we can stabilize the patient and we can support their recovery. And lastly, education is very important in patient care. So patients and their families need guidance on dietary and lifestyle modifications to prevent recurrence, and they need to know when to contact their healthcare provider for any worsening symptoms or signs of complications. So, in summary here, an intestinal obstruction is a significant condition requiring prompt recognition and management. Through a combination of symptom relief, careful monitoring, and education, we can optimize our patients' outcomes and we can prevent further complications. And that's all I have for this lecture. See you in class.